It's important to get an idea of what you are, exposing your patients to. Now, the different types of, frequently asked question, how does the selected current modality affect extent and type of tissue damage? Because most of the time you either use coagulation current or a cutting current or a mixture of both, which is the blended current or the endocut. What are the main risks of dithermy? Of course, the main risk is perforation, because you can burn a hole through the bowel wall. What practical steps can be used to reduce the risk, and what settings are best for clinical applications of dithermy? That is very much dependent on the type of equipment you have and what to do and what not to do. Okay? So how does the selected current modality affect extent and tissue types of damage? So first of all, we'll see what sort of dithermy do we do. The common one that we normally use for our, snare snare polypectomy, sphincterotomy, are the monopolar type of thing, in which you attach a plate to the patient, which is quite broad-based, and as it is a broad-based plate, there is less resistance, so it doesn't heat up, and that's important. And the circle is completed by the tip of your dithermy appliance, which can be either a sphincterotome or a snare. And then it involves a lot of physics, but we need to keep it nice and simple, because that becomes so. In monopolar dithermy, as you saw in the diagram, the current passes between the endoscope accessory and the patient plate, and the surface area of the accessory is much smaller, so you get heating there, and that is what produces the dithermy current and the localized heating. The large return plate, which is very important that it has good skin contact, it completes the circuit, but it spreads it around. Normally, when you apply the plate, the nurses or your technicians make sure that there is no metal prosthesis under it, because it might cause burns inside the patient. So we always ask the patient if he's had any hip or knee prosthesis, or you look for a scar of the operation on the hip, which is quite obvious. So in that case, if there is any prosthesis, use it on the other side. The other important thing that you have to do is that it should be good skin contact. The plates that we use are disposable. I don't know, some places use the reusable ones, so they are quite good. But we ensure that it is a hairless area. So if the patient has got a hairy skin, you try to shave that off. And the Right, so those are the sort of simple examples of the monopolar one. Bipolar dithermy is the type of dithermy that we use in something like bicap or heater probe, in which case the two electrodes are combined in the accessory for, like gold probe, heater probe that we use, and the current passes into the tissues between the points in the probe. So the patient does not need to be grounded with a plate. So so a return plate is not required. But for all practical, this is only used in a very limited situation. Most of the situation you use the monopolar dithermy. Right, so that's bipolar basically. Right, the types of current that we use. Cut current is a low voltage current, and low amplitude, which is low wave current form, it heats tissues very quickly and cuts through without causing damage to the tissue. So in if you got it on pure cut current, the damage to tissues is minimal. The cut is nice and clean, but it is a bloody cut. It doesn't seal off the blood vessels. It doesn't coagulate them. So if you are using cut current, you have to be prepared for bleeding. And that used to happen a lot in ERCP, because in ERCP, when you do a sphincterotomy, you do not want too much coagulation current, because it causes quite a lot of sort of distortion of the ampulla. Your cut should be as neat and as clean as possible, but obviously you have to balance it out. So we used to use a blended current, but nowadays you've got the endocut, which is a combination. Coagulation current, on the other hand, is high voltage, high amplitude current. It heats wider area of tissue, slowly resulting in deeper tissue damage, sealing of the blood vessels. So it is more it is useful for coagulation, for hemostasis, but not a very clean current, not a very clean cut. Blend, in fact, combines cut and coagulation currents. In the past, we used to have the crude Olympus-type blend currents. Nowadays, you've got more advanced endocut currents, which combines phases of cut and coagulation, very high frequency, very clever system. And most of your new diathermy machines are programmed. So the YO2 Urbis are very clever. You can just set the programs in them. One of the most important things to remember is that the extent of damage extends beyond the area of visibility. You might see that it looks, you've done a good job, but that extends, the damage goes deeper. So that is something which we have to be very cautious about. Now this is a diagrammatic representation of what happens at the ground level. So if you imagine that is your cutting wire, immediately, it's okay. Immediately in contact with the cutting wire, you get a tissue which is totally dehydrated and it evaporates because of the intensity of the heat. Because that's a very high temperature, so it is well beyond 500 degrees. It's about 1,000 to 2,000 degrees Celsius. So that causes complete vaporization. Then you see more, that is carbonization or vaporization of this. So you see black charring. Wherever you see black discoloration of the tissue, that is carbonization, which is quite high temperature. Then you see coagulation, which is seen as a whitened tissue. So most of the time, that is what you want to achieve with your thing. And then even beyond coagulation, the tissue might look normal, but it is devitalized. It's killed off, right? So coagulation usually occurs at 60 degrees, and devitalization, where the albumin of the tissue coagulates, occurs at about 40 degrees Celsius. So be aware of this bit, because this is very important, the devitalized tissue, because you might not see it, but you might have caused a full thickness burn. Now, amount of current of our heat generated in the tissue depends on the current density, because the closer, if the snare is close to half its initial size, the current density will quadruple. This is simple physics, which I've forgotten now. As initial current is applied, the tissue is desiccated and electrical resistance in the tissue increases. Because as you keep going, the conduction and the tissue becomes more and more devitalized and coagulated, less current goes through it. So sometimes you see that when you are doing a polypectomy, everything stops, and the temptation is to increase the current intensity, and if you do that, you get a sudden, zipper effect. So don't do that. If power is increased, there's risk of rapid cutting through the center of the polyp, or you may get a zipper effect in the polyp, in the sphincterotomy. So always resist that sensation, be patient. Again, normally when you are cutting a big pedunculated polyp with a big thickened stalk, especially with these new pre-programmed machines, it's always a good idea to give them a forced coagulation current beforehand, before you start your endocut current. And the important thing about that is that you try to seal off the blood vessels. The way to do it is that you give them a forced coag for a few seconds till it all goes blanches, it goes white. And after that, you normally start off with your endocut current. Especially with the newer machines, you don't take your foot off the pedal, because the endocut current would not work if you try to do it intermittently. You press your foot down and keep it there, and it will keep on changing the cycles from coagulation to cutting current. So that's important. Sometimes when you've got a very big polyp with a big stalk, and it's a pedunculated polyp, we use a technique which is known as EVR, and epinephrine volume reduction. You inject adrenaline, 1 in 10,000, 2 to 3 mils into the stalk of the polyp. You inject another 2 to 3 mils in the head of the polyp, It's always difficult if it's a villous adenoma because you don't quite get into it, but manage to do it and leave the polyp for 15 to 20 minutes. That especially if you find the polyp in the sigmoid colon, you inject your stuff, leave it, complete your colonoscopy. When you come back to it, the polyp has shrunken by that time and you can remove it more safely. So always aim for any safety procedure that you can do. Sometimes, if it's a big polyp, we put an endoloop snare around at the base of it, and then you put your snare above the endoloop polyp. The only problem I have with that is that we use that very infrequently, and sometime if I've got a nurse who's not familiar with it, they mess it up because it's quite fiddly the way, and it might make things more difficult for you. So I've stopped doing that. You can put a hemoclip at the base, and normally if it's a thick stalk polyp, you may need to put 2 or 3 hemoclips. I used to do that, but I was put off because sometimes when your snare touches the hemoclip, it can dissipate current and cause quite large extensive burns. And in fact, it happened to one of my patients. Fortunately, it didn't perforate him, but he had a very extended burn over his mucosa. So I've stopped doing that as well. So I just pre-coagulate it, cut it, and if there's any bleeding, go for that, right? What are the main risks of diathermy? Perforation is the commonest risk. So it's very important to detect it early, and it's due to excessive current or failure to prevent tenting of the mucosa. Because sometimes when you catch a polyp in a snare, especially if it's a flapped polyp, and you tighten the snare, the mucosa gets sucked under it into the snare, and if you cut it, you leave a big hole there. So try to avoid. So when you snare a polyp, it's always a good idea that when you engage the snare, to move your snare up and down, to and fro, to make sure it is free to move and it's not got tenting in it. And again, it is something which polypectomy, you should do it supervised by somebody who's good at it. Sometimes, which can easily happen, is that there's a late perforation, and that can occur due to excess current. As I mentioned to you, the diagram of devitalized tissue, you may get full thickness burns without you realizing, and after a day or 2 or even a week, that gives way. Or sometimes the patient strains that stool and it pops, and it can cause late peritonitis, late perforation, right? So at times you do not get a full perforation, but you might get a transmural burn, and it causes the same symptoms of peritonism, except that there is no free air under the diaphragm. Most important to remember, always at the back of your mind, you should remember that the colonic wall is paper thin. Right colon, the thickness of the wall is 1.5 millimeters. Left colon is about 3 millimeters. 3 millimeters is not particularly very thick, but still it is better than right colon. So whenever you do any therapeutic work in the right colon, you should be very careful about the type of current that you use, whether you are doing polypectomy or doing APC treatment, organ plasma coagulator, because in the new ERBI machines, they have got a special program for right colon in organ. Sometimes I've seen people who have done carried out APC treatment for angiodysplasia in the right colon and perforated it. I mean, that's a real shame, because for such a minor, trivial thing, you cause a perforation. So number one, personally, I'm not very keen on doing APC over there. Even if I do it, then I inject some saline under the angiodysplastic lesion and fire the APC on top of that, and that gives it a bit of protection. So whenever you are doing any polypectomies, any EMR, I do lots of EMR on the right side, but we do it safely. We inject fluid under the flat polyp and remove it, and it's not a problem. But always treat it with respect. Never give excess amount of currents there. One of the most important thing is that in our department, there are no hot biopsy forceps. We've totally done away with them, because what people tend to do is they catch a flat polyp in the hot biopsy forceps and completely burn it off, and by the time the hot biopsy forceps is burned off, it has caused a full thickness burn or a perforation in the colon. So no hot biopsy forceps in our department. the general recommendation is not to use it in the right colon, you can use it in the left colon. What we normally advise is, number one, if it's a flat polyp, we do it and EMR resection on it. Number two, if it's a small polyp, less than 5 millimeter, you just do a cold snare on it. Snare the polyp in a, and just ask the nurse to cut it through, and that's it. Or you can just take a cold biopsy from it, and usually, because it's a real disgrace if you take a 2 mm polyp out and cause a perforation. So, and that polyp might never cause any problems in future, and most of the time these polyps are hyperplastic. So be careful with using hot biopsy forceps. We never use it in our department, but if you are really pushed to use it, only use it on the left side. And again, I would advise you, those polyps can be very safely removed if they are less than 5 millimeters in diameter by simple cold snaring.
I think it's very important if you're going to use it. I totally
Yeah.
agree with what
Yeah.
I was saying.
Yeah.
If you're going to use it, it's even more important in this to keep it completely away
Yeah.
and just burn the tip. Mount Fujiyama kind of thing, you have ice at the top.
Yeah.
You don't want the whole thing getting white.
Yeah.
If you keep it really fast and just do a little burn, that's enough. You just want to burn the tip. You don't want to burn the whole.
Exactly. So there's a fine line between one extreme and the other. If you don't give enough current, you'll get bleeding. If you give too much current, you get perforation. So you have to balance it out. So bleeding, it can be early, and if the cut is too quick, or you've got your assistant is not good and they apply too much pressure and cheese wire the polyp stalk, then you will get bleeding. Because then, or if it's a thick stalked polyp and you do not give enough precoagulation, it might, or if the vessels are cut at an angle. If it's early, it's not such a big problem because you can see it, you can put a clip on it immediately, or you can coagulate with the tip of a snare. What I tend to do is take a snare, open it just slightly at the tip, and use that and use a coagulation current on it. But if I feel that it might burn the hole through, I might just use a clip on it. Sometimes if the bleeding is brisk, you can't see, don't panic. Inject some adrenaline around it and wait. And that will blanch out the area for you, clear up your field, and then you can go and put a clip on it or catch it in a snare or use a heater probe on it. And at other times you can get late bleeding. It can occur a week up to 10 days, after the polypectomy. The important thing about late bleeding is that you should warn the patient that everything went very well, but there is a possibility you might bleed and it might occur a week to 10 days later. So if any signs of bleeding, get straight to the emergency department or give your number. So what steps can you take to minimize the risk of diathermy? Number one, before you use any machine, you should be familiar with its settings. Because I remember I went to Paul's department and they had bought the new YO2 machine, and a lot of them were having problems with it because it had never been demonstrated. We were using exactly the same machine, but the rep from the company came and spent almost half a day with each of the consultants and we taught us how to do it. So I think it is very important that whatever machine you use, you read the literature about it and you know how to work it. Review pathology thoroughly. If you got a flat polyp, I normally inject all my flat polyp. If it's a small polyp, we inject some normal saline, and if it's a bigger polyp, needs extensive EMR resection, then we use a combination of gelafusin, indocarmine, and adrenaline combination, so that the fluid is not absorbed very quickly, and you can use endoloop device. You can use the endoloop device, but as I said, you should only use it if you are using it on a regular basis. In our department, we use it fairly infrequently, and if I got a new nurse, it is quite fiddly, she can't work it and makes a mess of it. And especially these are big polyps, so you don't know. So I tend not to use it now. I just use a polypectomy. If it bleeds, then I just catch the blood vessel. I found it very, very tricky, so I never use it. This is what I normally use, precoagulation for thick stalk polyp, and that works quite well. Or sometimes nowadays I use the EVR technique, inject the adrenaline into it and then come back to it. And with this, flat polyps, we use some fluid to lift it up. The fluid helps in causing tamponade anyway, so it will minimize the risk of bleeding as well as perforation.
How much injection do you give with adrenaline? Blanching is what you're looking for a little bit?
No, if you are using EVR, endoscopic, epinephrine volume reduction, then use about 10 mils in total. So 3 to 4 mils into the stalk and 3 mils into the head. And leave it for at least 15-20 minutes, because like in one case I was just doing a flexible sigmoidoscopy. So I did it, came out, went to the coffee room, had a cup of coffee, had a bit of a chat, and then went back in again. But if you are doing a complete colonoscopy, then complete your colonoscopy, come back, and it would have shrunk. Because if you go in too quickly, it wouldn't have shrunk. It will still act as a hemostatic agent. Most important thing of all is never take a polyp out if you can't get to it. And that's what I've been trying to drum into your mind, the 5 o'clock position. If you cannot maintain the polyp in your 5 o'clock position, you will never be able to do a satisfactory section. So always, if you get into a 5 o'clock position, it flips back, ask one of the nurses or your assistant to hold the scope for you in position. Because only once you've got an optimum position on it, you should only go for it. Because the problem is, you might catch it from an awkward position, but in case anything goes wrong, you cause a perf or you cause a bleeding, then you won't be able to get to it. So always be in the most comfortable position so optimize your position. That can not be overstressed, because that is the most important thing. Not just for the procedure, but even for the occurring complications, right? So anything. And the other thing is, make sure that your snare has not caught normal mucosa. There's no tenting. Avoid overuse of diathermy current, especially in right hemicolon. Most important. Always remember 1.5 millimeter. Your left colon is still better, but
you use the coagulation when you're doing left side in terms
I don't
of
use, I use minimal, yeah, because we've got this new Irby machine, YO2000, and in that there's a separate setting for right colon. So you just use that. So you just use a right colon program, which is a lot. For APC, again, there's a separate setting for it. I mean, APC, I always use minimal current. Now, I've got these settings for some of the older machines, so if they are in your department, you can use them. If not, then what we were using when we started bowel screening was that they were using the IC200, which is so now obsolete. And what we did was that the currents we used was, if we're using this was in the old machine, so it doesn't really, the autocoagulation force was, if you were using power of 15 to 30, low end of the range in right hemicolon with blue foot switch. But it's not a good idea to use a lot of coag in the right colon. Polypectomy force coag with endocut, again the power was, for autocoag force was 25 to 30, up to cut 200 watts of current, effect 3 on endocut on. That was with the endocut program. And precondition is blue foot switch. Blue foot switch is the coagulation, and yellow for the endocut. So this is a common one that people used to use, but those machines are old. I mean, we got the new one, but if you still got that in your department, you use that. Right, okay. Right. And this is how the endocut works. There's a cut, coagulation, pause, cut, coagulation, pause. So when you don't hear the sound, you still should keep the foot pedal on. It will work the cycle, because if you don't put it on, you will abort the cycle. So always when you are using endocut, keep the foot pedal pressed, and it works itself. Again, for argon plasma coagulation, I use a lot less setting than this, 25 to 30 watts, because APC, it is safer, but it can cause perforation. So use the minimum amount of current needed. What to do, what not to do. Number one, be familiar. The important do's is be familiar with the diathermy unit in use at your center, because they are all different. So check settings carefully. Consider use of cold snaring for small polyps less than 5 millimeter. So always a good option even if it starts bleeding, it's not going to, the patient is not going to exsanguinate to death. You can, it will stop bleeding itself. Be aware of potential thermal damage. That is the damage which is not seen by your eye, that is beyond your vision. Don't use hot biopsy forceps in right colon. In fact, in our department, don't use hot biopsy forceps at all. Don't use prolonged bursts of coagulation current because that can cause more tissue damage. Don't forget to check secure patient plate attachment because otherwise it will cause unnecessary burns. And don't use diathermy unit until the scope or snare position has been optimized. That is the most important. That's why I keep on telling you 5 o'clock position. And the reason I keep on telling you to get the fluid pool into 5 o'clock position is for the same very reason you need to practice that. Because you should be in control. You shouldn't be trying to do it from an awkward angle because that's where problems can occur. So always be in command. Thank you.
Thank you.
You mentioned two energy sources like density, urban plasma, and we have other options as well like harmonic. Harmonic for pulvectomy or colonoscopic version.
Maybe don't use that. Surgical.
But do you use bipolar at all in endoscopic setup?
Bipolar imaging, you use it as a heater probe. And it's quite useful for peptic ulcer bleed. Because if you can see a bleeding vessel sticking out, you can use it's very good because it's got a jet of water flow in it. So you can direct the jet at it. If there's a clot adherent to the ulcer base, the visible vessel, you can wash the clot off with the heater probe jet, and then as soon as the vessel starts spurting, you can put the heater probe straight on the vessel and use tamponade, and at the same time buzz it. And you use what we call footprints on it, little dents in it. So yes, heater probe I use quite a lot for bleeding ulcers.
Where do you use the APC?
APC specifically for angiodysplasias, for post-radiation colitis, for watermelon stomach, sometimes for clearing out the tumor ingrowth from stents. We use a different setting for that. Sometimes for extensive bleeding from a tumor, and just spray that with APC.
Do you spray current at all?
Pardon?
Spray anywhere?
Spray.
Use a
Large,
spray current.
large surface if you have that you want to stop, like you said, if you want to work on tumor, you're not going to work specific, you have to go for
Yes, sir.
for a
Spray form of APC, like you just use it.
APC uses spray form, but
Right.
do you use current for spraying? I mean, we do use spray. Diathermy spray. Diathermy spray.
What's the spray?
Diathermy spray.
They are saying that there's a more spray within the regular diathermy as well. Do you ever use that?
No, it's still facility. There's no facility for it.
No, there is no facility in the endoscopy.
Heater probe, there's an inherent pump, it's got a built-in pump in it, so we use that.
And do you have the choices of diathermy or APC depending upon the site of bleeding?
Oh, we got it all in the same machine, so you can just switch over whatever you like. Like, when I